The purpose of this episode is to explore common health and well-being issues for people with Down syndrome. This content is not intended as a substitute for direct medical care by relevant professionals. Rather, we hope to share new and important information so families and supporters can be well informed when accessing medical care. Your individual's medical or educational professionals may have recommended different practices or procedures that are specific to them. Do not modify or change your individual's treatment or therapy plan without consulting with your care provider.
Today on the Lowdown, a Down syndrome podcast, Dr. Bulova gives us the lowdown on healthcare guidance for adults with Down syndrome. Over to you, Nina and Mara.
Thanks, Jody. Our episode today can be considered a companion piece to an episode from season 6, where we discuss the healthcare guidelines for children and adolescents with Down syndrome. Now, we know that the life expectancy of people with Down syndrome has increased dramatically in the last half century, from 25 years to an average of 60 years, and largely due to improved medical care. So today, we will be discussing the healthcare guidelines for adults with Down syndrome, which are equally important as the medical picture can change drastically as individuals with Down syndrome age. We're very fortunate to have one of the lead authors of the guidelines joining us today. Dr. Bulova is a professor of medicine who has an undergraduate at Brown University and then went to the University of Pittsburgh for medical school, internal medicine residency, and chief residency. He is a past president of the Down Syndrome Medical Interest Group and is on the Global Foundation Task Force for creating evidence-based guidelines for adults with Down syndrome. He teaches medical students, residents, and fellows at the University of Pittsburgh and is a member of the university's Academy of Master Educators. Welcome to the Lowdown, Dr. Bulova. Thank you so much for joining us today.
Oh, I am so excited to be here. Thanks for having me on. I think I'm so happy to hear that this is a topic that interests you. It's very near and dear to my heart. I've been seeing adults for 20 years now.
Oh, absolutely. Yeah. And I think this is some much needed information for our families and listeners from around the world. So we're so excited to have you. Okay. So in the grand tradition of the Lowdown podcast, we like to start off our interviews with 5 secret questions so our audience can get to know you a little bit better. Are you game?
Sure.
Excellent. Okay, awesome. Okay, so I'll start off with the first question. What was your favorite subject in either elementary or high school?
Elementary and high school. I think it was, I have to say, I think it was math.
Yeah. Great.
I think I wanted to be a paleontologist back then too, so dinosaurs, but
yeah,
I mean,
didn't work out.
It still looks fun though.
Yeah.
For sure. I'll do the next one. So if you could sort of magically become fluent in any language, what would you choose?
Oh, I would definitely say sign language. I think that would be a fantastic one to be able to communicate.
Yes, absolutely. I agree with that one. Next question is, would you rather visit a volcano or a rainforest?
I think they both sound fantastic.
Really? I think volcanoes sound terrifying. I want nothing to do with them.
Well, if it meant I can go to Hawaii to get to a volcano, I think I'd probably pick that one.
Fair enough.
Yeah, I guess we didn't specify dormant or active volcanoes, so that'll help with the decision making.
True. Next question is, if you had a time machine, would you rather go back in time or into the future?
I guess I can't go back to my dinosaurs things I've already used.
I mean, you could. You probably wouldn't last long, but you totally could.
Probably not. No, I would love to go into the future, just even 100 years to see what happens next.
Oh boy. Wouldn't we all?
Yeah.
And then the last question, do you have a favorite sandwich? And if so, which type?
Sandwich. Well, being in Pittsburgh, I have to go with the permane sandwich, which I don't eat very much, but I love the idea of it because it's sandwich that has French fries on the sandwich.
Oh, really?
It's a Pittsburgh legend.
Okay. That's cool.
I love everything about that. Yeah.
Thank you. Thanks for indulging us in those questions. Our goal is always for our listeners to recognize our guests are people, and not just really big brains. So with no further ado, let's get into the topic at hand. And the first question I want to ask you is, what's the main objective of these adult healthcare guidelines? What's the goal here?
So what I think is most important is that there are somewhere between 20 and 25 adult centers for adults with Down syndrome around the country and few around the world.
Mm-hmm.
So there are just not enough experts to see all of the adults with Down syndrome. There's hundreds of thousands of adults. So we were trying to put out some sort of guidelines for primary care providers to be able to care for our adults.
Mm-hmm.
I think our job is an awful lot easier than the pediatricians. We talk about so many medical issues. So much of them occur before age 5. So I think our job's a lot easier. And I'm hoping that I can give your audience and some take-home points of what are the main things that they should be focusing on in those golden years, the 20 to 40, where people do really well.
Mm-hmm. Absolutely. Yeah, I think that's a really good point that you made, that there's just not enough specialists to go around. And certainly internationally, I know that to be the case as well. We don't have Down syndrome specialized centers here in Canada beyond like our own clinic, which is not primary care. So it's very hard to find any physician really who has a high caseload percentage of people with Down syndrome. So these healthcare guidelines really fill a gap there.
Yeah, my goal would be to put myself out of business. I would love that primary care doctors and providers would know enough about these guidelines that centers aren't needed anymore.
Mm-hmm.
Yeah.
Mm-hmm. Can you talk a little bit about how the guidelines came about? When did they start? How many revisions have been made? We talked with Dr. Bull about the pediatric healthcare guidelines coming through the AAP, which is a very complicated process. What happened in the case of the adult healthcare guidelines?
So the first guidelines that came out were in 1999, and they were just put out as a pamphlet, and it was only to a very small audience. I was looking back through my emails, and in 2004, I read this email that said, we really need to put some guidelines together. So that was 19 years ago.
Okay.
It's a lot harder for adults in that, just as you said, life expectancy has skyrocketed, which is fantastic. But it also means we have very little research-based evidence for adults because we haven't had so many adults before. I like to say that if life expectancy was, if you look in the 20s where life expectancy was 9, and now it's up in around 60, like you said. If this for those without Down syndrome, if they had that same increase, we all live to be 350.
Yeah,
absolutely. That's a good perspective moment, for sure.
So that's the I think that's the main idea about what we're trying to do with them. So this iteration started in 2016, and it's been a 5-year process for putting them together. To make true evidence-based guidelines is quite difficult, as I'm sure Dr. Bull told you.
Yes.
So it took us altogether about 4 years to get from our first starting meeting to publication.
That sounds about right. Yeah, it's a complex process. Can you tell me who's on the team? Who's deciding what goes in, gets changed, gets taken out?
Yeah, so this was one of the best parts about it. It was really fun. I got to work with some of the legends who've been working with adults with Down syndrome for decades and decades. So mostly through the Down Syndrome Medical Interest Group, as well as the Global Foundation in Colorado, just got together who had the most experience in working with adults with Down syndrome and some specialists in those fields. So we started with more people that took primary care of adults. So this was Brian Chacoin and George Capone and Dennis McGuire. These are really some of the legends that have been doing this for forever. And then we added Terry Harville, who's an expert in immunology and rheumatology. Kent McKelvey, who actually just passed away last year, but was with us throughout the entire guideline process, and he runs a center in Arkansas. Moya Peterson has been doing this for 25 years. Barry Martin, I think he was been doing this up in Colorado too, working just with adults. And then on top of all of the primary care providers, we added specialists in all of the different fields that we'll be talking about today.
Mhm.
Altogether, I think we have 25 people that helped out with our 9 lead authors.
It's incredible. And the names you just listed off, it's like the celebrity all-star cast in our world where we're like, oh, these are the great people. Like we are so indebted to them and their service for sure. When we think about, I'm going to start and then Hannah will take over into the medical piece by piece part, but can we talk a little bit first about how the medical picture changes as individuals with Down syndrome are aging?
So the good news is most things get a lot easier.
Which is great. Parents need to hear that.
Yeah. So the way that things change, there is some early aging. So we start to look for things. That's why pediatricians are not very comfortable taking care of adults, because you'll often see some of the things that I see in my geriatric populations at a much earlier age. I remember a pediatrician referred a patient to me with osteoporosis in their 20s. The pediatrician was not happy about trying to treat osteoporosis.
Sure, yeah.
That they never see.
So, Dr. Bulova, let's kind of jump into a few of those key medical areas that are listed in the guidelines, but also perhaps we might see with some of our adult clients here, and kind of talk a little bit about what the guidelines say for each of these areas. So, how about you start us off with perhaps behavior?
Sure. And I think behavior, one thing that we looked for in the guidelines was what was different than what Dr. Bull put together. They did some pretty fantastic work. Much of it does carry into adulthood. And I think for behavior, you'll probably see a lot of the same things. When we made these guidelines, we went through, I think it was 11,000 articles just to find things that would match with the topics that we covered. We only found of those 22 that were truly evidence-based, and we were able to come up with true meaningful guidelines for them. So a lot of what I'm going to tell you, some things are kind of a statement of good practice, and some things are more evidence-based. So I think when we look at behavior, it's much more, this is a statements of good practice. And I think they're going to sound pretty familiar to you. So the most important one is doing some sort of a behavioral review once a year, because our patients don't always tell us what's going on, they show us. And if there is a behavior change, it's often their only way of telling us that there's something going on. So doing some sort of review every year about behavior. And then the second part of that is that if you see a new behavior, don't immediately refer someone to a psychiatrist or a psychologist. Start looking for some sort of underlying medical issue.
Yeah.
So if I have a patient that becomes, is incontinent, my first step is not going to punish them for being incontinent. It's going to say, what are the possible medical things that can cause that? So maybe this is atlantoaxial instability, and this is how it's presenting, and our patient doesn't have another way to tell us that. So whenever we see a new behavior, start with looking for a possible medical issue.
Yeah, and that's really related to what we see in pediatrics for sure, where we understand behavior to be some kind of communication, certainly, and we understand that things like localizing pain are difficult for people with Down syndrome. Communication certainly is difficult in a conventional sense with sentences and words. So we rely upon what we can observe in somebody's behavior to tell us that there might be something physically that could be seen to that might help with the behavior, rather than it being something willful or we hear a lot of manipulative, and we don't really go with that.
Yeah, exactly.
That is a great point.
Yeah. Dr. Bulova, what about dementia? It's gaining a lot of more traction in the research field, but in terms of the healthcare guidelines for adults with Down syndrome, what does it say about dementia?
So the good news and bad news is, the good news is there is much more data about dementia, but that's because it is so prevalent. So we had this is probably our strongest recommendation, and 2 very important points, and it all relates to the number 40 or age 40. So dementia is quite common in adults, especially in their 50s and 60s. So I think that the data is something like 55% of those between 50 and 59, much more high in the higher areas of 50, higher numbers, will have dementia, and over 75 in those over 60.
Yeah.
But the numbers below 40 are incredibly low. And really just about unheard of before age 35. And a lot of people refer to my clinic for rule out dementia when they're 28 years old. And so the main point is that if somebody is showing a decline in skills, or you're concerned about something in these 6 domains that we see with dementia, and they're under the age of 40, that's when you have to do a very aggressive medical and as well as behavioral or psychiatric workup for what else might be causing a decline in skills.
Yeah.
I think the biggest part of my job, the thing I get the most I find the most rewarding, is undiagnosing dementia.
Yeah, I get that.
Yeah, and a lot of times. So I've had a patient who would come in with someone who came in with she was tearing her shirt off in public places in her group home, and they thought that she was becoming psychotic, and they thought this was the first stages of dementia. But when we talked to her, it only happened in the dining room, and she was always pulling her shirt off from around her neck. And it turned out that she had terrible reflux. And once we treated her reflux, her dementia went away.
Yeah,
and
that is. It's a great example of looking at the behavior and saying, what else could be going on here? For sure.
Yeah. And I think it's important throughout, I think all of these things that we're going to discuss, like you said, Dr. Bulova, we really have to be detectives and figure out all the root causes of what it could be, because it really can impact how someone is supported and treated if we go about it the wrong way. Let's kind of jump over to things.
Real quick. So over 40, we do a screen every single year. Look for it. So we have a form that we fill out. It's a 6-page behavioral assessment form, and it goes over 6 different domains. And I'll do that starting at age 40 in everybody.
Yeah. Okay.
Do you recommend that families take what I would consider to be baseline data in the form of like a home video of, this is my person, this is how they're doing, this is the things that they enjoy doing, for their own point of reference?
I think that's a great idea.
Yeah.
Picture's worth 1,000 words.
What about diseases such as like diabetes and the impact of obesity and diabetes?
So with diabetes, we actually found some nice literature about this, and it looks like it is more common in people with Down syndrome, and it occurs at a younger age. So the rate was much higher in those between about 16 and 30.
Okay.
So in the general population, I don't screen for diabetes, but what we found was that we should do some screening for those with Down syndrome. And again, just as as you mentioned, it so much is related to weight. So in those who have a BMI of 30 or more, we start screening at age 21. And if your BMI is below 30, you'll wait to do screening until about age 30.
30, okay. Yeah, so it's really important to kind of get an eye on that earlier on so that it can be managed well as they get older. What about cardiovascular disease?
And this is one I always like to think about. What are the benefits of Down syndrome? Because there are several, and we'll talk more about those in our next set of guidelines. But for this one, what I've always found is that the rate of cardiovascular disease seems to be much lower. But I often see people coming to my clinic on medications for cholesterol, probably don't need them. So what we found is that it did look like there was either the same or a lower rate of cardiovascular disease, so that you can use the guidelines that we use for the general population, looking at 10-year risk. And having used that, I haven't found anybody that's qualified for a statin, at least in the patients that I see. So it seems to be a low rate. In terms of strokes, the ones that are more common are in people that have congenital heart disease. So we're much more aggressive in looking for strokes in people that have congenital heart disease and making sure that they have a cardiologist.
A cardiologist on the team, yeah. I know that in the pediatric guidelines, this is the atlantoaxial instability is, it's quite a predominant part of the guidelines, and it is something that a lot of families ask about, and we as OTs think about as well. What are the adult healthcare guidelines view on AAI?
So there isn't great data for adults regarding this. So a lot of our guidelines relate to the pediatric guidelines. There is no reason to screen an adult for atlantoaxial instability unless they have some sort of symptoms. And I think that the only difference might be that we do see sometimes some different symptoms in adults than you might see in kids. I saw someone who used to be right-handed and they changed to left-handed, and that was their presentation of atlantoaxial instability. Drop attacks in older adults and fainting. Those are things where we would start to look for it. But no screening for somebody who's asymptomatic.
Yeah. And I think that's the one thing with the pediatric guidelines, so that they've now broken it up into symptomatic and asymptomatic. So it just helps you kind of guide your decision making a little bit more. So that's really good to know. You had briefly mentioned osteoporosis earlier. What about that?
So we had lots of questions about osteoporosis, and we didn't find a huge number of studies about it. I thought this was telling that the rate of osteoporosis in the 6 small studies that we found was somewhere between 1% and 45%. Which is not helpful at all.
That's not very useful.
Not useful at all. What we found is that the rate is probably higher, but the way that that we diagnose osteoporosis is using bone density scans, DEXA scans, which have never been proven to be effective for people with Down syndrome. So we don't know if they get more fragility fractures. We don't know if treatment helps. But we do know one thing, which is that there are lots of secondary causes of osteoporosis. Especially in our patients. So we're very careful. If you do have a diagnosis of osteoporosis, if you have we call it a fragility fracture. Fragility fracture is one when you break a bone when you probably shouldn't have, or you have a compression fracture in your spine, something like that. And the things that we'll screen for, and I think these will all sound very familiar to you, and we'll be talking more about them, which is we'll screen for hyperthyroidism, which can cause osteoporosis. We'll screen for celiac, and we'll screen for hyperparathyroidism, but that's probably not any more common in people with or without Down syndrome.
Yeah. Well, you led that beautifully into my next 2, which was thyroid and celiac disease. So take it away. It was perfect timing.
Exactly. So Dr. Bull says that we should screen do thyroid screening every year. And what we found for adults is that, yes, you can still develop hypothyroidism at any time. So there is no upper limit of when you stop screening for thyroid. You can relax a little bit. You don't have to do it every single year. You can do it every 1 to 2 years. But again, that's more good practice than it is a good true evidence base. But our guidelines state every 1 to 2 years to screen for hypothyroidism. And I always say keep an eye out for hyperthyroidism too. It's a lot more common in our patients.
I wanted to ask you a bit more about that. Are you more likely to see hypothyroidism in an individual with a history of hypothyroidism? We have some families that we see here who treated hypothyroidism, seems to be fine now. They're off medication. Should they be more wary and move that up to like the 1-year mark? Or is it still okay for them to kind of alternate 1 to 2?
So if they have been diagnosed with hypothyroidism, is that what
that's correct? Yes.
Yeah. As long as they're asymptomatic, every year, every 1 to 2 years is fine. The minute you're starting to see behavior changes or weight changes or constipation or changes on their neurologic exam, then move it into the to the symptomatic as opposed to asymptomatic screen check more commonly.
And just to be clear, I'll just repeat what you had said earlier. I think I'm correct. You said hyperthyroidism, so Graves' disease is more related to osteoporosis. Is that correct?
That is correct.
Okay. So
and then the second thing that you mentioned was celiac.
Yeah.
And I believe in Dr. Bull's guidelines, they say to screen everyone and then screen again if there are symptoms. There wasn't any evidence that we should rescreen adults. I think that they haven't been screened as a kid, sure. But we didn't see that catching celiac early prevented a lot of long-term problems. So only if someone is symptomatic. But again, symptomatic can mean a behavior change, but especially if it's a weight change.
Yeah.
or some sort of gastrointestinal symptom.
Symptoms. Okay. Dr. Bulova, are there any other areas where more research is needed to expand the guidelines? Like what is the next version looking like?
Thank you for asking that question.
You're very excited.
Great. Oh yeah.
Yes.
Yeah, I'm very excited about this. So we found when we published these guidelines, there were a couple of glaring areas that we missed. And I think you probably have covered them many times in your podcast and in your clinic with your patients. So having gone through this round, and again, this was a very time-consuming process, having a group go through 11,000 articles, we couldn't cover everything we wanted to cover. So the areas that we're most interested in, the first one is obstructive sleep apnea, and try to come up with some good guidelines about that. And I think mistakenly we thought, everybody knows about sleep apnea. We don't need to put out a guideline for it. But
no, we wish. Yeah.
So absolutely. And at this point we say screen every year with looking for symptoms of obstructive sleep apnea. But as I think you are aware, we don't always see the symptoms. But that's the first of the 5.
Right.
I don't know if you've talked with Sarah Mann before.
Yes.
Yes.
Yeah.
So our superstar in terms of physical
PT.
therapy.
Yeah.
And so that's going to be another one of our topics is physical therapy.
Interesting. Okay.
What's beneficial? What do we have in terms of evidence towards that? And, and we talked about before with obesity, we don't have any perfect intervention that works for everyone. In fact, there was no study that showed that we had an effective intervention. We're hoping that the combination of treating both with diet as well as with exercise together, that we might have a little bit more true heart outcomes for that. So those two. Vision is a really important one. And we already have some clinics that are opening up for adults with Down syndrome because cataracts and keratoconus are so much more common and easy to miss because they happen in 20s and 30s.
Yes.
And then the final 2, and this is the benefits of Down syndrome, we hope, is the solid cancers seem to be much lower prevalence than for those without Down syndrome. So do we have to be as aggressive in screening for things like breast cancer and colon cancer when they seem to be much rarer in our patients? And then finally, blood cancers, which are very common in the pediatric population, but a lot less common in adults. So this is leukemia, lymphoma, things like that.
Yeah.
Can we go back to sleep for a moment? Now, my understanding of the research is that parental report is not exceptionally reliable, just because a lot of sleep apnea, or OSA, as we call it sometimes, is what we would call silent or atypically presenting. So what do those assessments look like in the adult population? Are you having somebody come in every year for a polysomnogram, or are you just asking parents through a questionnaire? What does that look like?
So the polysomnograms are quite difficult to do.
Yep.
And
people don't love it.
No, they're quite expensive. And if you have a negative study in an adult and you don't see a new 25-pound weight gain or a new major behavior change, that study is pretty good, and we'll rely on that for quite a while.
Okay.
So we're again looking for behavior changes, decline in skills, things that are much less specific than snoring. And I don't know if in pediatrics, if you talked about sleep positioning.
Sure did.
Yeah.
Yeah,
atypical.
Sleep in some pretty amazing positions.
Yeah.
Oh, it's incredible. Some of the pictures that families bring in, and it doesn't look very restful, is what I would say.
Our patients are pretty good about taking care of themselves in that way, that they self-treat their own sleep apnea by sleeping face down or something like that.
Yeah, exactly. Yeah. And I think with sleep apnea too, some of the interventions are not the most favorite for our population beyond the surgical. So the CPAP or the BiPAP, those things are not well tolerated. So it's one of those things that is harder to introduce as you get older. So it is something to kind of keep an eye on in early adulthood so that they're well managed as they get older. I was also so happy to hear about the PT exercise inclusion, because we know there's lots of research out there that says that increased exercise for individuals with Down syndrome is very, very beneficial, and they need higher intensity, higher frequency of exercise. So really happy to hear that that's kind of being part of the guidelines as well.
I'm hoping
Amazing.
we'll look at some other endpoints and not just weight loss.
Yeah. Absolutely.
Participation would be great. Yeah.
Yeah.
Absolutely.
Helps with digestion, helps with so many things, even with sleep, right? So it's and even with mental wellness, I'm noticing that with a lot of my clients that are going through a regression or going through some mental wellness issues, the importance of physical exercise is really, really paramount. So it's great that that's kind of being included. Dr. Bulova, if a parent or caregiver is having trouble, this is something we hear all the time, especially with things like assessments for obstructive sleep apnea. They're having a hard time convincing their physician for a sleep study, for example. As a physician, what would you recommend families do given what's in the guidelines?
Right. So the one for sleep, we don't have that in this current set of guidelines. I think that if you go to the Global Foundation's website, we have a very convenient one-page handout, which lists what is evidence-based and what should be done on a routine basis. And it's very easy for a primary care provider to look at this sheet and use it.
Right.
I think that it will be very helpful. For sleep apnea, boy, it really helps to have bringing and it doesn't take too much. I think there are some other really nice guidelines out there. So I wrote a review in the British Medical Journal in 2014. So just bring that along, and it has big section on how important it is to screen for sleep apnea with any type of change.
Yeah, great.
And just be empowered to take that to your doctor.
Absolutely. Yeah. And I think it's such a great thing that you, with your team of physicians that are writing the guidelines, with the Down Syndrome Clinic to You thing that Dr. Scott co-started, all those things are so great that they're helping bring that information to the family so they can feel empowered to take it to their physicians. In your bio, I had mentioned that, part of your job is to train medical students, so the up and coming doctors. How do we kind of help them at that training point to understand more about Down syndrome, to maybe convince them to specialize in Down syndrome? And it's like, what does that look like for you when you're training the up and comers?
This is one of the favorite parts of my job, is getting a chance to work with medical students. I am so impressed with the students that are coming through now. They tend to be incredibly empathetic, want to change the world, which is so great to see. What we do here at the University of Pittsburgh is on the very second day of medical school, we have a course called Introduction to Being a Physician. And we have a half day where we interview someone with Down syndrome and their family in front of the whole class.
Awesome.
And then we break into small groups, and we have 20 or 25 of our patients, and they come and just chat with the medical students. And I'm amazed at how wonderful just having that exposure is. And I'm sure you both know, just having time with people with Down syndrome, it really makes you want to help the whole population. And I just feel like I'm a better person for the time that I've had working with adults with Down syndrome. And I think that's infectious. I think it really does wear off on medical students.
Yeah. That's wonderful.
And other fields, not just the doctors, I think.
Yeah.
Every
and that's a very good point. It's not just the primary care physician. There's lots of other areas of medicine where something like this can be very helpful for their training. I also wanted to just quickly mention, you were talking about the one-page checklist. One of the great things I love about the adult healthcare guidelines is that you have a parent-friendly version. I think you have, taken feedback from the key stakeholders, the families that are part of the process, to have a version that's less jargony, a bit easier for families to understand, and then therefore they can advocate for their loved ones better. So that was wonderful. Were there any other resources that you would like our listeners to look for? And we can put a link on our episode page.
Oh, sure. So I think that the global site is very good for both finding, if you're looking for an adult center, they have a listing of all the adult centers. And I don't know if they have ones listed in Canada. I hope they do. I hope they do have that too. As well as the guidelines and the family-friendly guidelines.
Yeah.
I love DS Connect, which is part of the NIH, and it has what are the studies that are going on right now. And in terms of resources, I love having podcasts just like this one that reaches out to families. We have one at the University of Pittsburgh too, that's run by Dr. Velody. That's a nice resource. And then the NDSC, the National Down Syndrome Congress, their website's fantastic.
Right. All wonderful resources. Dr. Bulova, thank you so much for taking the time to chat with us today. This was informative for us as well. As I said, Marla and I are self-proclaimed medical nerds, so we really enjoy this kind of stuff. But I'm sure this is going to be so helpful for a lot of our families and for listeners around the world. So we thank you for your time.
Absolutely. And have me back in 2025 when we have our next guidelines out there.
With pleasure. We will.
Yes, please. Yeah, we will for sure. Thank you.